Hey everyone, Dr. Kaveh, live here to talk about what we can do to help prevent you from remembering your surgery and being awake under anesthesia on the operating room table, connected to that ventilator back there. And believe it or not, as afraid as you are about being awake, so are doctors. I once had a patient who was a world famous surgeon themselves. And I would have thought that this surgeon would have been so cool and relaxed here in the operating room. You wouldn't believe it. He pulled me aside. He literally tugged me right before we walked in the room. And he said, "Anthony, I don't want to be awake." He literally whispered so that no one would hear him because they were freaking out. They really wanted all the medication they could possibly get. And I don't blame them because even though the odds of being awake for surgery are very low, almost on par with being struck by lightning, it's what we call a high impact, low frequency event. The problem is that I see these patients in my clinic for ketamine treatment or for stellate ganglion blocks after they've had this traumatizing experience. And I appreciate the nightmares, the depression, anxiety, the PTSD, even the heart conditions that can happen afterwards. And that's not to mention avoiding medical doctors after losing complete faith or trust in the system. I mean, being awake for surgery can be so terrorizing and so frightening that it might prevent patients from getting the care that they need. So I want you to take away from this video, from our live stream today, specifically how we monitor patients for awareness or wakefulness, what the difference between being awake and having anesthesia dreams is, because dreams are real, and as so many of you ask me about them, and also what you can do to help us help minimize that risk as much as possible. We're going to have a little bit of live Q&A at the end, so definitely stick around for the end so I can answer your questions. And it is so important to first zoom out before we even talk about the monitor, which, yes, I will connect myself to. I'm wearing the EKG leads for you guys specifically. You see all the shiny stuff here? It's not body oil, it's actually ultrasound gel, because I was just filming a video with an ultrasound, which you'll see in a little bit. It's just very goopy and kind of gross. I'm sorry. It's curious that we are incredibly lucky as human beings that as we are going to sleep under anesthesia, your brain goes through several layers of anesthesia. So when you are in the lowest or most superficial, I should say, layer of anesthesia, we scramble your memories. And as you go deeper and deeper, we'll make you unconscious. The question is, how do we monitor along the way to see where you are so that we don't keep you too light instead of being deep enough to scramble all those memories and really render you unconscious? Because even scrambled memories can still cause problems because the body might be keeping score of what's going on. We have lots of tools in this operating room. I'm going to show you what they are, but recognize that if we cannot match the depth of anesthesia that your brain and spinal cord need to not have any awareness, we run the risk of you having some memory or your body feeling some degree of pain that might be problematic in the future, even if it's not at the top of your memory, because scrambled memories is not the same as no memories. And patients might have a delayed diagnosis for days or weeks or maybe even longer because they might have nightmares or all sorts of symptoms that we cannot explain without remembering the traumatic experience that triggered them. Because when they're on this table, they have all sorts of medications like various doses of propofol, maybe ketamine, etomidate, gases like what we see here in the ventilator, laughing gas. And if you don't know the traumatic memory that triggered what you're feeling, we are not going to be able to diagnose you. And that's why there's such a delay in some cases of even minor experiences being brought up with doctors. Not all medications that we use for anesthesia paralyze you. Propofol does not paralyze you. Ketamine does not paralyze you. The gases that come out of here, sevoflurane, nitrous oxide, do not paralyze you. A certain class of medications derived from plant alkaloids, in particular curare derivatives, do paralyze your body without wiping your memory. And if we have too little memory wiping medication and too much paralyzing medication, that is the setup for the most traumatizing type of awareness. Fortunately, that is very low. It does happen sometimes, which is why we're talking about this. But recognizing that, fortunately, we can monitor a couple of really important parameters. The first is something you're going to see on here. Now, I'm going to do a little demonstration. Every one of these monitors that we use in surgery should have a gas analyzer connected to a little tube like this. Can you see that? No, you can't. Maybe now you can see it. Still no. I don't know. This guy, when we breathe into it, it is sucking the air through all this tubing, coming all the way back to here. And you can actually see my breathing based off the carbon dioxide that's coming out. So if you look closely, let's zoom in with our camera to see what you can see on this monitor. Oh, that's me. Whoops. All right. So as I'm talking, you're going to see carbon dioxide coming out right here in white. And you can see the measurements of oxygen and carbon dioxide in the air that's being sampled by this tube. You can also measure the concentrations of anesthesia gas that are coming out in that tube. We can also sample how much anesthesia gas you are exhaling out. You see it in the same spot on the monitor. And that is how we can measure what the equilibrium is between the gas that you're breathing out, which is correlated to the level of gas in your brain. And that is based on the MAC, what I've listed here. It stands for not a Big Mac hamburger, but for the minimal alveolar concentration, meaning the amount of anesthesia gas in your lungs alveoli, the air sacs in your lungs, that corresponds to a certain level of consciousness. Now, this is based on population averages. This is super important to remember because not all patients are the same. If you are an average human being at a certain exhaled concentration of gas that we're measuring on that gas analyzer, we correlate that to how deep you are under anesthesia. And hopefully wiping your memories and rendering you completely unconscious to minimize the risk of that mismatch that can lead you to be awake. The problem, as you're probably already asking me, is one, what if someone's different? What if someone uses a lot of cannabis and they're not the average patient? We're going to talk about that. Also, what if someone is not having any gas? What if they're just getting IV or liquid anesthesia, propofol, ketamine, or something else that's keeping them completely unconscious? How do you measure that? Well, that leads to number two, which is this concept of the brain monitor. Literally looking at your brain's EEG, or what we call the oh my gosh, I guess I had a brain fart. Electroencephalogram, the beauties of being live. The EEG can be a correlate of how deep you are under the coma of anesthesia, whether you're with gas to an extent or with liquid anesthesia. The problem is that not all medications impact your EEG the same way. Ketamine and nitrous oxide coming out of that ventilator back there actually excite your brain. Very curious, and as a really quick sidebar, my work with ketamine patients for resistant depression or PTSD or anxiety is probably dependent on that activation of certain parts of the brain. The problem in the operating room is that it messes with their ability to see how deep under anesthesia you are based off of your brain waves. So if we don't have the gas analyzer, because you're not breathing anesthesia gas in and out, maybe just oxygen and nitrogen, then we don't have the same level of granularity, especially if we're not just using pure propofol to use those brain waves. So it's not just ketamine and nitrous oxide that are problematic with brainwave monitoring. It's also problematic with muscle contractions. So when you clench your teeth like that, you are generating a large muscle signal on the scalp of your brain with the temporalis muscles, the masseter muscles, etc. That's picked up on the EEG, and algorithms cannot always distinguish muscle contraction from brain activity. And when we paralyze a patient, a certain level of electrical activity goes down because your muscles ain't contracting. If your muscles are not contracting, we might have a false reading on the brain monitor. And if we have that false reading on the brain monitor, well, you might run the risk of that mismatch, which is why we also need to, number three, monitor how deep you're paralyzed. We have these twitch monitors in every operating room. I'll show you, for example, what we're looking at here. And, well, I guess Well, that's maybe a little embarrassing. I don't know where the Twitch monitor went in this room. Well, I'm not going to use it on myself. It's actually very painful. We put an electric current through muscles that we have access to when you're under anesthesia, whether it's in your wrists, whether it's on your face. And based on that muscle twitch from the electrical current, we can deduce how deeply paralyzed you are. The more deeply paralyzed you are, the greater the risk of you potentially being awake, but not being able to tell us because you can't move your muscles. Fortunately, most surgeries do not need muscle paralysis. Most surgeries with the appropriate use of IV or liquid anesthesia and gas don't need appreciable paralysis. Some surgeries we actually cannot use paralysis for. So that's a really good sign if your anesthesiologist is using the right amount of anesthesia, not too much, not too little, but just the right amount, and hopefully minimizing muscle relaxants whenever possible. Muscle relaxant is just another name for paralysis. Now, number 4 here is this important concept, which is like the most holistic and fortunately age-old and cheapest monitor we have. That's your heart rate. Before we had all these gas analyzers and brain monitors, the anesthesiologist would place their finger just over your facial artery here and measure your heart rate, or over your pulse here. Because if you are awake and paralyzed in surgery, your heart rate is going to shoot up. Your blood pressure will shoot up. Your respiratory rate will increase if you're not so paralyzed that you can still breathe a little bit. You might have purposeful movement, meaning you might try to grab the breathing tube out. You might you might kick the surgeon. You might make movements that try to minimize pain to your body or to signal what's going on. Your anesthesiologist has to be watching very carefully to make sure that you're not doing any of those, because that is the most classic telltale sign. Now, often it's too late if that happens, but we want to minimize the duration of any awareness, and we need to always be watching. Now, you might be wondering, well, what if I just have some memory of something under surgery? Is that the same as awareness? And the answer is absolutely not, because dreaming under anesthesia, especially with propofol or ketamine, is a very real phenomenon. And anesthesia dreams are so different than recall that we need to talk about them, and you guys ask me about them all the time. I want to do a quick reminder that if you're learning something new, please share what you've learned with your loved ones. Please hit that like button if you feel it's right based off of what I'm sharing. And if you're learning something new, subscribe to keep up with all my lives and let me know what else you want to learn about. Going back to dreams, about 20 to 25% of patients will dream or have some level of dreams with sedation, more common with ketamine and propofol than with anesthesia gas. In fact, ketamine dreams are so common that we even call them ketamine dreams if we're not giving benzodiazepines that will scramble your memory to prevent you from remembering. Now, dreams are not traumatic typically. In fact, they might be pleasant. Some patients love those dreams. And we need to distinguish them from awareness because, sorry, a little distraction there. Dreams are not a source of anxiety for patients when they're asked about them after surgery. Being aware is. So knowing that dreams are possible, not to be panicky if you have them, is very important, especially when you're first waking up from anesthesia and surgery, and there's a lot of stuff going on. The big question now is, what can you do, in addition to knowing about the existence of anesthesia dreams, what can you do to help us minimize the risk of awareness? First is you got to be honest with us, because certain things will change your ability to resist anesthesia and take you away from the average. Remember that I told you that that gas analyzer there is heavily dependent on where you land on the average spectrum for anesthesia resistance and tolerance. So if you use drugs, opioids, benzodiazepines, cannabis in particular, alcohol, you're going to need higher anesthesia doses, and you need to tell your doctor so that we can dose you appropriately. Patients that take glucocorticoids or steroids or anti-epileptic drugs, AEDs, may also have higher anesthesia tolerance. And we need to know that so we dose you appropriately. If you've ever been told you have a difficult airway, you totally need to let your doctor know, because if you have difficulty with being intubated, you run the risk of being paralyzed and maybe having some awareness during that incredibly stimulating and painful part, potentially painful part of surgery when the breathing tube is going in. So if we know that you have a difficult airway, we're going to dose your anesthesia differently, but we need to know that first. Bottom line, if you tell us, we can use different medications because we know that some medications are more likely to result in awareness. Barbiturates are probably more common to lead to awareness than ketamine, or its use with benzodiazepines, or very high doses of the anesthesia gas. But if you don't tell us what to be mindful of, we're not going to know. So with that said, we're going to jump into our live Q&A. I hope you learned something new. If you haven't already, please hit that like button. I see so many comments here. I can't wait to start answering them. And already IV ketamine making you massively nauseous. So Denise, I'm sorry that sounds like you had that experience. Ketamine is typically not associated with as much nausea as anesthesia gas or opioids. So actually, ketamine in some ways can be a nausea relieving technique with surgery. CRPS, Denise, I'm sorry to hear about that. Ketamine can be used for CRPS. I use it in many of my patients who come to me with intractable CRPS where everything else has failed. It's a terrible condition. I hope you have not been suffering with it. Jody, good to see you. More ketamine. Ketamine therapy for depression is a lifesaver. Well, B. Clendenson, I have seen it in numerous of my patients. It absolutely can be. It's not a miracle drug. It has to be used with the right supervision in the right patient, but absolutely can address the mind-body connection. My cardiologist has the best. Okay, I don't know why they have that TARC. And usually we give ondansetron. Yes, we do. It's one of the 3 main medications we give in addition to dexamethasone and metoclopramide. So how ketamine works for depression, I have lots of videos. I have many videos on it. Please check it out or check out my website where I have loads of articles on all the science, claris-health.com. You will learn more about ketamine than anywhere else, I think, on the internet. Now, thank you for this super thanks. Lack says, getting a stent for a pinched vein out of the left kidney for nutcracker syndrome. I've woken up several times. Thank you for encouraging me to get blood in my urine checked. Well, I am so happy that you had that blood in your urine checked before ketamine, because ketamine-induced cystitis is a very real complication of inappropriate ketamine use. It's not really been reported in judicious uses of a finite number of ketamine exposures. I hope that your surgery is going to go well, or that stent placement for your kidney, and I hope that if you do receive ketamine treatment, that it helps with whatever you're trying to treat, whether it's depression, anxiety, or PTSD. I'm really wishing you the best. Thank you for sharing that. Hot water nurse, where does that name come from? Do they use paralyzing agents in strabismus surgery? They might at the very beginning to place the breathing tube. I take Spravato for depression. How does this affect me going under anesthesia? Well, you need to let your anesthesiologist know, because if you have a tolerance to S-ketamine, you will likely have a tolerance to racemic ketamine, or the traditional form of ketamine used in the operating room. It is unlikely to be significant, but you need to tell your doctor so that they can make that decision for you. How does MS play a role in anesthesia? Ziggy, it plays a huge role, especially in temperature regulation, to make sure that you do not get too hot. We also need to be mindful of the paralyzing agents that we use, in addition to any other nerves that might be compromised for nerve blocks or for other parts of our anesthetic. So you need to let your anesthesiologist know. Cindy is talking about vivid dreams under ketamine, the ketamine dreams. You're absolutely right that they can happen. I like to let my patients know if they're going to get ketamine from me during surgery so that they are prepared. And I also want to make sure they have enough propofol so they don't just have unbound ketamine dreams, but something that buffers. The goal is not to have anyone have an unpleasant experience, certainly, under anesthesia. Hey, Donna, thank you so much for the super thanks. Very kind of you. Tyler has had multiple bowel resections, and your videos show me so much when I go for well, I've helped you so much. I'm so grateful for that. I hope that anyone here who has a family history of cancer, or personal history of polyps, or any other concern that your doctor or gastroenterologist may have, is not afraid of getting those colonoscopies. It can be so easy with propofol administered by an anesthesiologist, and absolutely, I'd like to say, better than having colon cancer go undiagnosed. Why do redheads redheads require more anesthesia. We don't know, possibly related to a mutation in the melanocortin-1 gene that seems to be responsible for many redheads out there. Anyone who reacts yuck to ketamine does not need it. Well, necrotic napkin, interesting username, by the way. I don't know if that's true. There's very rarely any all or nothing statements in medicine. Some individuals don't know what ketamine is and they might respond with yuck. Some individuals might know what ketamine is and respond with yuck. And those are two different patient populations. But I agree that ketamine is certainly not for everyone. No medicine is one size fits all. Please never let any YouTube doctor try to convince you of that. It's not medicine. It's someone trying to, it's like a snake oil salesman. Oh, enjoy that gallon of water. Ringo, oh, you're talking about the colonoscopy? Oh, it's not water. It's much worse. Donna Sharon, I've had ketamine 4 times. Once for surgeries, knees, had surgery. And it's helped you with your PTSD. Well, I'm so happy that you had that improvement with your PTSD. It's pretty rare to have improvements from ketamine during surgery, but it's wonderful if you feel that it helped. Jim is saying, for TKA with a spinal, what protection does sedation provide? If you have a spinal and you're not feeling the pain, sedation can help you feel more comfortable in a room full of strangers with banging and reaming on the femur or on the the femur or the tibial plateau. You don't necessarily need sedation, but it often makes it much more comfortable given everything else going on. Hey, if you guys are learning something, by the way, do please hit that like button and share this knowledge with others, because the more knowledge you have, the more empowered you can feel and better you can advocate for yourself in our broken healthcare system. Can genes affect you waking up, possibly? And is there a test that can indicate it beforehand? We don't know of any genes that will predispose you to waking up. There are some genes that might predispose to you needing more anesthetic. We're still learning about those. AG is acting about legal recourse on awareness. Yeah, of course there can be recourse if it was due to negligence. We have no evidence to suggest that the majority of awareness is due to negligence. It might be due to any other number of factors, including difficult decisions when patients are in emergency surgery and their bodies cannot tolerate a high enough dose of anesthesia for unconsciousness because their heart might fail. And if it's a question between death and possibly risking awareness, it's a very challenging question that we need to answer. In emergency situations, we will tend to try to keep a patient alive at the expense of possibly having a risk of awareness. That's why we use ketamine and benzodiazepines like midazolam to help have the highest chance of wiping memories with the lowest impact on overdosing, the anesthesia. We can have a whole video on that. If that's what you want me to talk about, I can talk about it in the next video. How we address emergency surgeries to minimize the risk of awareness. It was not rednecks, it was redheads, my apologies. Hey, Juana, you're so welcome. You are so welcome. Someone asked about psilocybin, and that's a great, the psilocybin use adversely affect general anesthesia. Not to my knowledge, though there may well be an increase in the dose of anesthesia needed depending on how much psilocybin is used. But we really don't have much data because psilocybin use is not regularly reported in studies. I was given ketamine for my hysterectomy back in February. It worked better than most other anxiety meds. Wow, that's incredible. I wish I could pronounce your username. Merch Chicken Lover? Mr. Chicken Lover. I got it. It's not typically used as an anti-anxiety medication, but some individuals can respond very well to it. Very good question. Are there different types of anesthesia? Yes, there are. I just talked about a whole bunch of them in this video, and there's even more that I have not mentioned. And I'm so sorry to hear about the workers' comp team causing PTSD. It can be so challenging in the United States. I don't know how much better the insurance system is. It's challenging for everyone. I hope that you have a supportive care team around you and at least a supportive family unit at home. We'll end with Gabby here. Ultrasounds are gross. Had one on the neck and one for the placement of a clavicular block. Well, Gabby, I just filmed a video on the super. That's why I have all this goop here on my collarbone, because I was showing where my brachial plexus lives, where I would numb it for a supraclavicular block. and a little bit about the technique of how we do that. Be on the lookout for that short coming out soon. I want to answer one last question. Um, well, that one is a probably no to start, but let's end with Jody. I was wondering if anything is reported if someone has any issue during anesthesia. That way, other anesthesiologists would know. If there was a serious issue that another anesthesiologist should know about, I always tell my patients so that they can take that with them. I will even photocopy my anesthesia notes and say, hey, if you ever have surgery again, be sure to give this to your anesthesiologist. Don't assume that the patient's going to remember what you tell them when they're kind of woozy and groggy coming out of anesthesia. That is not a good practice. I want to make sure that if I saw a potential complication, which I have had before, that might be preventable, I absolutely tell my patient and give them as many records as possible so that, and it's in plain English, not doctor speak with abbreviations that nobody knows, but in plain English so that they are empowered to take it with them to their next doctor. Well, hey, you are all so welcome. I hope that you learned something new, Truth Humble, and everyone else that left all these positive comments. Remember, you have more power over your health than you've ever been told. Please advocate for yourself. It's a broken healthcare system. I cannot fix the system, but I can help you better champion for yourself and your loved ones.